Right. So, welcome everyone to the.
Interrupt you, sir. Your slides are not visible. You need to share once again.
Yes, I will. So, welcome to our IC on human amniotic membrane preparation and applications. So, I'm joined by Dr. Tuhin and Dr. Aditya, when we will take you through the process of how to make your own amniotic membrane. And we'll also show you surgeries on where an amniotic membrane can be used. So we do not have any financial interest in the talk. We will be mentioning some commercial products and proprietary material, but no financial interest. So this is how the course is outlined. So I'll begin with the mechanism of how an amniotic membrane actually works, and then show you videos on how to prepare your own amniotic membrane. Then Dr. Tuhin will show you how the amniotic membrane is useful in acute ocular conditions. And then Dr. Aditya will show us how the amniotic membrane can be useful for surgeries in ocular surface healing. And then two of us will again take you through some miscellaneous uses of the amniotic membrane. Dr. Samar Basak will also be available for expert comments later on. So coming to a little bit of history before I begin. So it was first described in dermatology back in 1910. But the first use of in ophthalmology was in 1940 by D. Roth, who used it for a conjunctival defect. And then Sorsby and Simons used it in 1940 for chemical injury. However, from 1990s, Schaefer-Seng and his group, they really catapulted the popularity of amniotic membrane. So as you can see by the timeline in PubMed by the number of publications, so there's this huge exponential increase from 1990 onwards. If you look at the basic anatomy, and if I'm not labeling this, you would mistake this to be a corneal, it's a histology of the cornea. However, this actually is what the amniotic membrane microscopically looks like. It has got an epithelium, then the basement membrane, which is collagen-wise very much similar to the cornea. Then there is a three-layered stroma, which has got the compact layer, the fibrous layer, and the outermost spongy layer. So this is where the fetus is, and this is where the maternal side is. Now, if you look at the mechanism of action of how an amniotic membrane is able to do so many variety of surgeries, so it's actually a multifactorial therapeutic action. First and foremost, it has got no to low immunogenicity. So there is very limited HLA expression on the amniotic membrane surface. Therefore, even though it's a foreign tissue, there is not much of a rejection-like reaction going on in the ocular surface. Then it's a translucent material. So this is beautiful. So the patient can see something, they can see some of their visual improvement. And best of all, we as clinicians can see the improvement of our surgery. Then there is the mechanical support and moisture retention. So it has again the ability to hydrate and store water. So any dry surface, any poorly wet ocular surface is able to retain moisture. And then chemical wise, it is very similar to that of the cornea. And then it has got this huge collection of chemokines and cellular growth factors, a real alphabet soup going on there. Name it, it's there in the amniotic membrane. And the best part is, even after a storage at -80°, some of these chemical factors are actually preserved. So the amniotic membrane promotes epithelialization by going on to cellular differentiation, cell adhesion to the underlying surface, and then cellular growth factors. It has got antifibrotic properties by suppressing the TGF beta expression, anti-inflammatory properties by inhibiting the interleukins, interferon, TNF, and FGF, anti-angiogenic properties mediated through thrombospondin, endostatins, and various metalloproteinases, and antimicrobial properties by forming a mechanical barrier itself. And then you have these lysozymes, bactericidin, beta-lysine, and transferrin. Now, the types of amniotic membrane, I'll go over more details for the preparation. So we have the freshly harvested. This when you're working in a multidisciplinary hospital. So if you have a chemical injury patient, admit it, go to the OBG department, take a placenta, cut the amniotic membrane, and use it for surgery. Cryopreserve is when we sort of process it in the lab and we store it at -80 degrees in a tissue culture medium. Then these lyophilized and freeze drying, they are processed a bit more where the water is, let's sort of dehydrated. And the best part is this can be stored at room temperature. However, to the best of my knowledge, this is not available in our country. So we have these commercially available. These are again lyophilized and freeze dried kinds. So Procura is the most popular one. And this is not an amniotic membrane itself, but this is by Orolab. It's an Oro Amserter. So it's an amniotic membrane insertion device for quick and easy use in chemical injuries and Stevens-Johnson syndrome. And if we look at the types of the amniotic membrane surgeries, my co-instructors will be going more in details. So you have got the inlay technique. So here the amniotic membrane is cut to size, fits in like a puzzle, and it's sutured or glued to where there is the defect in the ocular surface, usually with the epithelium side up. So in the onlay or the overlay technique, we have it in the epithelium. So there's a debate going on here. So some authors describe an epithelium side down, whereas some authors go for an epithelium side up. So here the entire ocular surface, including the fornix and part of the palpebral conjunctiva, is covered with amniotic membrane. So this is more in case of chemical injury and Stevens-Johnson's. And then we have the filling in on layered technique. So this is a hybrid between the two, where layers of amniotic membrane are just piled on top of each other. So this is used to fill up tissue loss or say a small perforation. Coming to the preparation of amniotic membrane from placenta. So first and foremost, getting the placenta. So we get it from an uncomplicated elective C-section. Serology done, which is again repeated prior to the surgeries. So we already have 2 negatives for the HIV, HBV, HCV, and syphilis. And in our lab, we do a double check with the cord blood for the same. In the current scenario, a negative RT-PCR for COVID-19 is also mandatory. And ideally, it is to be prepared on the same day. So the materials, the chemical components that you need is the DMEM or the Dulbaco modified Stiegel medium, sodium bicarbonate, which acts as the buffer. Antimicrobials are penicillin, streptomycin, and amphotericin. Then the base of the media is a 1:1 ratio of reverse osmosis water or just sterilized water and glycerin. Normal saline for washing the placenta. Nitrocellulose paper as the carrier where the amniotic membrane is stuck onto. And sodium hydroxide or hydrochloric acid for pH adjustment. And the instruments that we need are a variety of graduated flasks and cylinders, a filter and pump with sterilized tubing, filter paper, pH meter, weighing scale, sterile bottles and caps, and heat seal and labels. So I'll be going through some of the videos that we have here. So we start by doing the serology from the cord blood. This is done in our microbiology lab under the laminar flow. So next, we prepared the base solution mixing the DMEM in 1:1 ratio of water and glycerin. And also we use sodium bicarbonate. This is to be maintained at pH of 7.8 plus minus 0.05. So the pH is adjusted by using the sodium hydroxide and HCl. So this is connected to the pH meter and we adjust the pH till we have a satisfactory reading. So next, once the solution is ready, we filter it using the pump mechanism to get rid of any undissolved particles or any impurities. So this is the filtering stand and this is a sterile tubing which connects to a pump. So it speeds up the process a bit. And the filter paper goes in the connecting junction here. Next comes washing of the placenta. So initially we just wash off all the blood and the clot that is clinging onto the surface. So this is done with normal saline, which is again mixed with the antibiotics. penicillin, streptomycin, and amphotericin B. And this process may be repeated twice or thrice till all the blood clot has been thoroughly cleansed. Once it is cleaned, now it's the time to harvest. So usually we get one of these cleavage planes of the amnion. This is a separation between the amnion and chorion. So once that is done, the other person sort of helps in just gently peeling the surface. And here you can see the amnion is separated from the underlying chorionic tissue. After separation, again, the amnion individually is washed thoroughly to get rid of any. And then finally, we apply these bits of cut pieces of nitrocellulose paper. So this has been cut into 3 × 3 inches. Then further, we will be stripping it down to size. So once the nitrocellulose paper has been stuck, then we take sterile scissors and then cut the amniotic membrane. Then this becomes a carrier which has got the amniotic membrane on it. So usually from a placenta, you can easily harvest about 45 to 50 pieces of amniotic membrane. Oops. So once all these nitrocellulose papers are dry enough, then we cut them into strips. So these are 2.5 × 2.5 centimeter strips. So depending on the requirement of the surgeons, you can size it accordingly. After the strips are prepared, then the culture media is bottled into sterile glass bottles. And then we put in the amniotic membrane individually. This is then sealed and labeled, and then finally stored in -80 Celsius. So along with it, what is the quality controls? We look at the culture, blood agar and Subero's dextrose agar is cultured, and the tissues, amniotic membranes are released for surgery only once both the cultures are negative. And the logs to be maintained are a freezer temperature log and a maintenance and distribution log. This is for your quality control purposes. Thank you for your attention. I will stop here and we'll move on to the next speaker, Dr. Tuhin Chaudhary, with his talks on surgeries. And I think we can do the question, answer, and panel discussion at the end. Over to Dr. Chaudhary, please.
Okay, is it visible now?
Yes, sir.
Yes, okay. Okay, at the outset, my sincere thanks to Soham for this opportunity. So next few minutes, I'll be talking on amniotic membrane transplantation in acute conditions. And then I'll show some of the conditions where even if it is not acute also, we can use it. So my focus will be mainly on chemical and thermal injuries and also on SGS. So regardless of the underlying chemical involved in acute chemical injuries, we have to do this medical management as well as the surgical management together side by side. So you have to remove the offending agent, we have to control the inflammation, we have to prevent infection, and then we have to control intraocular pressures. And in all the cases, we have to promote ocular surface healing. If we don't do that, then there will be a lot of cicatricial complications in later, that means up to 3 to 4 weeks time. So to promote ocular surface reepithelialization, there are so many ways. The most common way is amniotic membrane transplantation, and that is our focus for this presentation. We can use sometimes if you don't have any sort of amniotic membrane in your hand, you can use this large diameter bandage contact lens. We can go for tenonplasty or conjunctivalplasty. Sometimes we can go for limbal stem cell transplantation or congenital transplantation. So amniotic membrane transplantation, which can be used both as a graft which can provide a basement membrane for epithelialization on aerosol patch where it acts as a biological bandage particulars. So graft, as mentioned by Soham, that where this epithelium side is up and stomal side is down. So it can be helpful in both ways, graft as well as patch. AMT helps in ocular surface reconstruction, promotes rapid epithelial healing, and partly restores the limbal stem cell function. This is a case where this patient had the 6 years old boy had this tuna injury that lime particle was found still now in this upper fornix. So in all the cases, first we have to remove this offending agent and then thoroughly wash these types of necrotic tissues which is found in the superior fornix. You can see this how much it is necrosed, and all these areas should be divided. And after that, you have to go for 360-degree conjunctival peritomy. So if you see there means whole cornea involved, then you have to go for 360-degree conjunctival peritomy. Otherwise, only just area of this necrosis, we can use that much only. So you should remember that we should not damage these limbal tissues in these cases. So after this conjunctival peritomy, we are just putting this amniotic membrane and then just putting fibrin glue and then tucking this amniotic membrane under this cut conjunctiva.
कंटिन्यू दबाइए.
So now we can just close this dissected conjunctiva and then by using 6-0 Vicryl sutures. So sometimes even after putting this fibrin glue, you can see that this conjunctiva, this amniotic membrane may be displaced. So some surgeons put even is the circumferential corneal suture also in these cases. Now we have to address this area of necrosed for superior fornix. So again, another piece of amniotic membrane is placed over this necrosed area. Sometimes we can put this fornix forming suture also in these cases, but here as because that we have this glue, and that's why I didn't put any sort of fornix formation suture here. the cases this amendment can be stuck in this process. Just remove the plates, then this control to remove the 10 days. The patient who had no symptom of adjustment had to go on and the patient will recover the evaluation. Only food this medical representation to have to put this unit in the lead margins and then use this cases too much.
Wait for some time. And restart. Hopefully, I think we can wait time. So, so we actually have 25 minutes from now. So, Dr. please. Yes, sir. Yes.
Show that actively in the treatment window of patients should be ophthalmologist available with the current information and So it should be percent in a flow. His son asked me to see. I went and I did this very just months. See that there is solid improvement for put this in this and put a bit just to start in this margin. So community not known, but it is by minimizing the destructive effects of inflammation by maintaining a healthier structure. Important for as much of the renal rate and surface. So in this sense, if you put this is quite well is about if you have this facility, then in if you go for process. I'll be talking about the empty and subsequent. So, following chemical from then there is a touch distance of and that function there are so many surgical like this having this at least and so that's quite good. Not only video, can I put
So much, Dr. Sohan, for that wonderful talk, lovely videos. So we'll move on to our next speaker, the uses of in various surface reconstruction. Yes. So thank you so much for the opportunity. So on the same both of surface hearing as surgery, and surgery is also in different scenarios. So I'll give you the background of the first financial interest. So this was a 21-year-old boy who was originally from West Bengal, was working as a migrant helper in Kerala. During his work at he was sustained an injury to his head with an iron chain. They immediately showed it to ophthalmologist and underwent a corneal treatment on the X-ray. For some reasons, there was a persistent leak in the ventricles for post-corneal treatment. He underwent sacral tube application. Hospital about 2 months later, the repair. He decided to come back to his hometown, and since he was having persistent and diminution of vision, the hospital, the outdoor department, on the 16th floor. So this is around half a year after the application is set. The photograph and presentation is the ECL being nice background, and there was a vascular scar, lung-shaped projections
side of the original was transferred and was in the area. It was well formed, so to say. The video now. This video, the first was in the bandage, which was placed outside. Move the dog gently, but we go how to tackle this issue of unaffected blue. Checking if there's anything left. Just with the close the use has out, which is pause here and go back. There is a huge crater left behind where the blue came off. Heavily vascular is at least 60% of stomach thinning. So I decided to cover this membrane and cover the rest of the cornea. We have this disk of amniotic membrane at off. You on top of that crater and into position and to the surface superficially into the cornea for fixing it only for deep bites. This has been anchored by 4 interfacial sweetness. That another piece of amniotic membrane, which encompasses the entire diameter. Over this amniotic membrane and the rest of the with the post-operative, this is the day that the intense inflammation of the complete degradation of the amniotic membrane pieces should not also fit in. So this is the target of and the pieces of it removed. And see that the crater is completely there is a lot of that you have a very defined that actual and then amniotic membrane. The vessel started slowly regressing. Post 138, this again, inflammation. So the started to come and the faint outline not visible at the outset. In January 2001, that is almost 200 days of intervention. The video is even further more beautifully. Two take-home messages in this. One is that the application of amniotic membrane is definitely